the liquid biopsy field has evolved in the last decade from be able to detect first circulating tumor cells and the ability to essentially give a prognostic information about the outcome of patients with CTCs to a more sensitive technology looking at mutations in the DNA of the tumor. And these mutations over time have become target for drug development. So right now in the actual guideline for metastatic patients, we have indication for using cell-free DNA to identify mutation that can be targeted with drugs being approved by, and this has been, for example, PHEK, AKT, PTEN, in some cases, HER2, not only amplification, but also mutation, and ESR mutation. So there's been a tremendous increase on the use of cell-free DNA in metastatic setting. At the same time, though, technology has evolved and has become much more sensitive. So the first question addressed right now in our research field in the clinic is actually to detect disease at a very early stage before even the clinical detection of symptoms. So this is called minimal residual disease or molecular residual disease, depends on the technology and the test use. And essentially these patients, they have typically high risk of recurrence. So a triple negative breast cancer with a locally advanced tumor that does not achieve, for example, a complete pathological response with standard neoadjuvant therapy, with or without immunotherapy, is the typical patient with a high risk in the first 2 or 3 years of post-surgery and radiation. And similar for patients with significant lymph node involvement estrogen positive. So for these patients, there is no recommendation for any standard imaging. And this was the first slides of my presentation. We don't have any standard imaging recommendation, but we have a high-risk situation. Where do we fit the new technology for detecting early on any evidence of recurrence at the molecular level? And this is done essentially with 2 approaches. One is called the tumor-informed approach, where essentially you perform an NGS of the tumor that has been biopsy or resected, and essentially develop a signature. And this signature is going to be identified or not within the bloodstream of the patient's regular longitudinal timeline. And once the signal appears positive with a specific measurement, these patients have obviously probably already evidence of disease by imaging, or they are going to develop in the following months.